Good evening, doctors. On behalf of INTAS, I welcome you all for this live webinar on preventive treatment of migraine. INTAS has always been in the forefront. INTAS has always been in the forefront of promoting such academic initiatives for the welfare of the patients of the medical fraternity. To chair today's session, I am truly grateful to Dr. Rauf Ashmi, who has so kindly consented for doing the honors as a chairperson in today's program. Dr. Rauf Ashmi is a professor and head Department of Neurology at SKIMS Srinagar, as well as the chairman of the Composite Regional Center at Srinagar under the aegis of Ministry of Social Justice and Empowerment, Government of India. He has more than 50 publications in both national and international journals, and his area of interest is stroke, multiple sclerosis, and headache. I now invite Dr. Rauf Ashmi to take this program forward. Sir, please, if you can.
Thank you very much, Dr. Michael D'Souza, for such kind words. It's my proud privilege to introduce today's moderator, Dr. Sumit Singh, sir, who is a Chief Neurology and Co-Chief Stroke, Artemis Agrim Institute of Neurosciences at Gurugram. Dr. Sumit is a Joint Secretary and founder of Indian Headache Society. He's a founder member and member governing council Asia Pacific Headache Society, EC member of Indian Academy of Neurology. Dr. Sumit Singh has major achievements. He has started the first headache clinic in the government sector in India. He has started the use of Botox in headaches for the first time in country. He has co-authored the headache management guidelines for Indian subcontinent. Dr. Sumit has received BL Soni Award for Best Resident in Neurology, and he has more than 126 publications and 24 chapters in books. He's a reviewer of Cochrane Reviews in Neuromuscular Section and Headache. He is reviewer of the Annals of Indian Academy of Neurology and other international journals. Dr. Sumit Singh is a member of many professional bodies. He's member of Indian Academy of Neurology, Indian International Headache Society, Movement Disorders Society, Movement Disorders Society of India, and he's founder of the Indian Headache Society, Asia Pacific Headache Society. His areas of interest are headache, neuromuscular immunology, movement disorders, Parkinson's disease, and dystonia. I have been knowing Dr. Sumit Singh from once he was working in AIMS, and he was a inspiration for all junior doctors, and now he's working in private sector and doing very well in his academic as well as professional career. Today's webinar is on prophylaxis of migraine, and I would request Professor Sumit Singh, please introduce Dr. K. Ravishankar ji, who is the presenter of today's webinar on prophylaxis of migraine. Thank you.
Can I have Dr. Ravishankar's? Okay, so Dr. Ravishankar and headache in India are synonymous. There is hardly anything in the field of headache which Dr. Ravishankar has not visited, mastered, and tutored. He's presently the consultant in charge of headache and migraine clinics at Jaslok and Lilavati hospitals, and was trained at the Houston Headache Clinic and the City of London Migraine Clinic. It's sufficient to say that he's on the board of trustees for the International Headache Society, honored with the life membership and the special recognition award from the International Headache Society at Boston in 2013. He's on the editorial board of Headache Currents and a reviewer for cephalalgia and headache, editor for the book of Modern Day Management of Headaches, Question and Answers. He is a regular invited speaker at national and international platforms, and whatever scientific publications come out from headache, the most prized ones are from Dr. Ravishankar. He would be throwing light on the management of migraine, particularly in terms of migraine prophylaxis. Dr. Ravishankar, sir, kindly take charge.
Thank you, Sumit, for that kind introduction. And thank you, Professor Asmi, for chairing this session today. Let me share my screen and right. So we are going to be talking today on the preventive treatment of migraine. And it is very appropriate that INTAS have chosen this day to conduct this session on migraine because we are in the Migraine Awareness Week. So we are dealing with the subject at the most appropriate time. Now, migraine, as you all know, is one of the commonest problems we see in practice. But for so many reasons, it still continues to remain underdiagnosed and undertreated. Whether it is the lack of teaching at the undergraduate and the postgraduate level, or whether it is due to lack of interest on our part, or whether it is due to lack of focus. But the fact is that there have been a lot of advances in this field in the last 20 years, and there still remains, unfortunately, a huge gap between the theory and practice of migraine. So what I plan to do over the next 40 minutes is to fall back on my experience of working out of a headache clinic over the last 25 years and try and evolve for you a plan of approach to the preventive treatment of migraine. We'll be talking about the traps, we'll be talking about some tips, and we will try and show you how best to optimize the preventive management of migraine. I know that headache is one part of your practice, so I will keep it practical and simple. And as they say, sit back, relax, and get ready to interact as we take you through this session on preventive treatment. So how am I planning to roll out this talk? We will first give you an overview of migraine and talk about the burden, the unmet needs as far as treatment is concerned, a little bit on the spectrum that is migraine and what is new about the pathophysiology. And then we'll talk about why is there a need to revisit migraine preventive treatment, what are the principles, and what are the current options as far as pharmacotherapy is concerned. What are the alternative therapies which are underutilized in the preventive management of migraine. And finally, we will conclude by touching upon what is there in the future, the way that the preventive management is going to go. And we'll then wait for you to interact and ask us questions so that between the three of us, we will try and address all the issues about preventive treatment of migraine. Let me just see if I can minimize the panels here. Rahul, is there a way to minimize the panel?
Yes, sir. Sir, your screen is visible. Perfect, sir. Perfect.
Okay, but my screen to me is getting blocked.
Okay. So there is a hide thumbnail option.
Yeah, I got it.
Okay, yeah.
I got it, yeah. I'm fine now. Yeah, I can see my full screen now. Right, so let's begin by talking about the burden of migraine and the unmet needs. This is the logo from World Brain Day of 2019, when the World Federation of Neurology and the IHS came together with heavyweights like Bill Carroll, Lars Edvinson, the man who gave us CGRP, and Professor David Dodick. And the message that they wanted to convey to us was that, through the webinar, was that migraine is a common, disabling, legitimate neurological disorder. So the word legitimate is most important here because there are still people who think that migraine is largely a psychological problem. That's not the way that we need to deal with migraine. It has a huge prevalence in the peak productive years of one's life. It's the second most disabling neurological disorder in terms of years lived with disability. And in terms of cost, it's huge, $27 billion in a place like the US where it's measurable. And as far as treatment is concerned, the unmet needs are a low awareness, a wrong attitude, suboptimal treatment, lack of multidisciplinary care, and not using the latest options. Now, before we touch upon treatment, there are 3 slides which I want to put out so that we brush up on what should be known about migraine. This is the full spectrum as in the ICSD-3 of 2018. You will find that there are a number of new terminologies. Migraine with aura is subdivided into different subtypes. Basilar migraine, as we used to know it, is now called migraine with brainstem aura. Chronic migraine has got a separate rubric of 1.3. There are complications of migraine which are listed separately. And there is a category of probable migraine when you can't have all the criteria being fulfilled. And there are episodic syndromes which are seen in children, which are forerunners of migraine in later life. It is important to know this slide because if you can diagnose migraine, the subtype, then there is a choice of prophylactic according to the subtype you're dealing with. For example, the hemiplegic migraine and migraine with brainstem aura, you would preferentially go for calcium channel blockers. Menstrual migraine and vestibular migraine, you would have to manage differently. And when you have a migraine aura which is persistent, you might want to go with lamotrigine. So therefore, there are reasons for you to be able to subtype the type of migraine you're dealing with. The new understanding is important because we still find a lot of people addressing migraine as a vascular disorder, a vascular headache. You as the teachers of neurology to the internists and the general practitioners should no longer be using the word vascular, it should be neurovascular. There is a genetic predisposition, and whether it's in the cortex or in the brainstem or whether it's coming from the hypothalamus, that is debatable still. But the pain of migraine is definitely peripheral, and there is an activation of the trigeminovascular system. There is a release of neuropeptides, most important of them being CGRP. This leads to a vasodilatation, a neurogenic inflammation. The pain signals are transmitted centrally through peripheral sensitization to the trigeminal nucleus caudalis. From there on, the second order neurons take it to the thalamus and the other perceived pain perceiving areas in the brain so that we feel the headache. So therefore, the origin is in the brain. The vascular changes are a secondary epiphenomenon. So migraine is today to be looked upon as a brain disorder. So therefore the word neurovascular. And what is new in the field of prophylaxis is the recognition that CGRP is most important, calcitonin gene-related peptide. It's a pain signaling neuropeptide, which is most important in the pathophysiology of migraine. And following the role of CGRP being established in migraine, there were drugs which were established in order to tackle this rise in levels of CGRP. And so therefore, we first got the small molecules, the GPANs, and then because they would not work in preventive treatment, we then got the anti-CGRP monoclonal antibodies. One of them works against the receptor, 3 of them work against the ligand. And in future, we are going to be seeing other neuropeptides like PACAP, and we are going to have antibodies against the other neuropeptides. So it's important to know that the treatment landscape of migraine is changing significantly. And this is the best time to be in the field of migraine when you can deliver results much better than what we could have done earlier. And the most important part to understand when you're dealing with preventive treatment of migraine is to conceptualize migraine the right way, I call this a locked-in-like state, because once a migrainer, always a migrainer. It should be looked upon as a chronic disorder with episodic attacks, which change throughout the lifetime. Your genes, it's a genetically inherited vulnerability. The environment is the same, the genes are the same. You don't have still preventive drugs which are ideal for migraine treatment. So therefore, some migraineurs might improve, but most of them persist, some may progress. And because of comorbidities, disability, and risk factors, it is no longer enough to treat just the attack of migraine. You will have to prevent future attacks, reduce the frequency, reduce the severity. You will have to look at disease modification in migraine, just like you would do with an asthmatic or a chronic arthritic patient. So therefore, this aspect is where prevention comes in, where alternative therapies come in, where long-term therapy with minimal side effects. Nutraceuticals have a big role to play here. So therefore, it's important to realize that treating migraine attacks alone are not enough for a comprehensive treatment of migraine. So with that as the backdrop, let us now look at how do we go about treating the patient. Most importantly, no two migraineurs are similar. So therefore, the one-size-fits-all approach cannot work here. You will have to establish a rapport, understand the patient, and individualize or customize treatment for every patient differently. That is also done through patient education. You need to tell the patient why the head pains. You need to know what are the lifestyle measures you need to change in that patient, what are the triggers which are worsening his migraine. And every patient who is being chosen for preventive treatment must fundamentally have a satisfying acute treatment going on. So without this, there is no preventive treatment. And the three areas where we are going to focus on preventive treatment are, one is the pharmacological options, two is the non-drug, the non-pharmacological options, the alternative treatment options, and finally, the future treatments. So a good combination of control of lifestyle and trigger factors, a satisfying acute treatment, good preventive current pharmacological options, good alternative medicines, good biobehavioral management, and if need be, interventions which are in the future pipeline. Altogether, you can do a lot for migraine patients. So when you're looking at lifestyle measures and trigger control, you're looking at stabilizing the daily routine, doing the same thing at the same time every day, some amount of exercise, maintaining a diary of daily activities, identification of triggers, sleep hygiene, diet, controlling the stress levels as far as possible. So these are all prerequisites. And when you look at, do all patients need preventive treatment? Not necessarily. Patients who have less than 4 attacks a month, who have attacks which do not last for too long, 2 hours or 3 hours, the attacks can be tackled by using an appropriate acute agent. When the attacks do not significantly interfere with routine activities, they don't need preventive treatment. But if you have acute medicines which don't work or which have adverse effects, or if the patient prefers to have a preventive treatment, or if you have uncommon severe subtypes like hemiplegic migraine, even one attack is frightening, migraine with brainstem aura, migraine with prolonged aura. So there, even with one attack per month, a patient might prefer, and you have to give him preventive treatment. Otherwise, by and large, 4 attacks a month or more is when preventive is indicated. What do you want to achieve through preventive treatment? You want to reduce the attack frequency, the severity, the duration. Preventives also improve the responsiveness to acute treatment. They improve function, they decrease the disability through migraine, and they prevent progression of disease. A small number of migraineurs do progress. They have deposits of iron deposits around the periaqueductal gray. If you see the MRI, you will see these progressive patients showing different picture. And therefore, in order to prevent chronification of migraine, you would need to use preventives. But what happens in practice? This is from the AMPP study where they looked at 19,000 migraineurs. They felt that 40% needed prevention according to these criteria, but only 13% of an educated population were taking preventives. And at the end of 6 months, 26% only were continuing. And at the end of 1 year, only 17% were on preventives in spite of being started 1 year back. So because of poor efficacy, because of fear of side effects, because of poor reduced tolerability, for all so many reasons, people drop out. Adherence to preventives is very low. This is where you got to improve the adherence to prophylactics. So when you're choosing a preventive, what are the paradigms you want to follow? First of all, you got to establish a rapport with the patient, tell the patient why you're choosing drugs, why you're using preventives. You got to set the expectation right through patient education. Everybody wants to know how long, so many medicines. You got to choose your preventive according to the frequency, according to disability, stratify according to disability. Look at comorbidities, look at risk factors. Study the patient profile. If it's an obese patient, choose topiramate. Study the headache profile. If it's menstrual, migraine, perimenstrual prophylaxis is enough. Look at the contraindications, be aware of the contraindications and side effects of every prophylactic that you're thinking of choosing to use. Combine where necessary and limit the combination where necessary, opportunities and limitations. Drugs which work with different mechanisms of action can synergistically be used. And also look at future options besides the current options. Now, when you are educating the patient, what do you want to tell him? First and foremost, this is all coming from practice, what I see in practice. Do not give the patient an impression that you are going to be curing migraine. Migraine is only controllable as of today anywhere in the world. So tell him that he can be 60% better. He's not going to be 100% better. If he is, well, God has been kind to him. Second is, I find a lot of people telling the patient and the patient thinking on their own that what has been prescribed is a course of 3 months treatment. There is never a course for a migraine patient where the natural design of the disorder is linked to female hormones starting in 15, 20, coming down after 50, 55. So it's a long window period. There is never a course of treatment. You can reduce the medicines, but you can't remove the medicines. Third is different migraineurs, according to the threshold, will need different quantum of preventive medicines. So somebody might come and say, my neighbor got better with just 5 milligrams of flunarizine. Why am I getting so many more medicines? That's because your threshold is different. You're getting more headaches. And finally, you've got to reassure the patient that once the headache comes down, it's first the headache that should come down, and then the medicines which should come down. So therefore, you are going to be looking at reducing the preventives, but first after the headache has come down. How do you stratify based on frequency and disability? You've got to be aware of the headache days per month, out of which you've got to be aware of the migraine days per month. And a question which helps is to ask whether there are any days, crystal clear days in a month. And you got to assess the disability using these two questionnaires. One is the MIDAS questionnaire, another is the HIT6. And most importantly, what is not being done is to use a calendar. Now look at this calendar. It's so simplistic and easy to understand and diagnose chronic migraine and differentiate between episodic and chronic migraine. What is in blue are the headache days, but what is in red are the migraine days. In the calendar on the left, you have just 3 migraine days. But in the calendar on the right, for 3 months running, you have at least 8 days of migraine, which means more than 8 means chronic migraine. So therefore, you will have to maintain a calendar in order to understand where the patient is headed. And then look for comorbidities, most commonly psychiatric. You also have epilepsy and stroke comorbid. Then less commonly, you have PFO, Raynaud's, and fibromyalgia. and GI disorders like irritable bowel syndrome. While assessing for comorbidities, it is also good to ask regarding these questions in order to be ready for the prophylactic you're going to choose. So do you have asthma? Do you have IBS? Is there any PCOD? Divalproex if you're thinking of? Is there any depression? Don't go with flunarizine. Is there any glaucoma, topiramate, IHD, in order to know what are the options you have? Kidney stones, no topiramate. Diabetes, no beta blockers. Hormones, they can worsen migraine. So simultaneously ask for these questions, keeping in mind prophylactic preventive agents. And our job is to try and prevent an episodic migraine patient from being pushed further into chronic migraine. So what are the factors which can push a patient into chronic migraine? One is a high attack frequency. Two is obesity. Three is overuse of medications, analgesics containing caffeine, codeine, triptans, ergotamine, caffeine overuse, stress, and sleep apnea. We often tend to ignore or look out for sleep apnea. So this is important. And other markers are being established. Allodynia is one of the markers which indicates that the patient is headed towards chronification. Now, what are the agents which are available for preventive, which have been tried out? Look at the long list. It's huge. So many drugs have been tried out. These are all drugs which are borrowed from other areas of medicine. Why is there so much excitement about the CGRP monoclonal antibodies? That's because for the first time, we are treating migraine with migraine medicines, migraine-specific medicines. Otherwise, we were always borrowing from antihypertensives, we were borrowing from AEDs, we were borrowing from antidepressants. So therefore, this is the long list. But do we need to remember this long list? No. You can go with the guidelines. The most prominent guideline is the guidelines of the American Headache Society, or the AAN 2012 guidelines. And then you now have a 2019 guideline, which is very useful, where the AHS has positioned the new treatments into clinical practice. Then you have the Canadian Headache Society guidelines, guidelines of the European Federation, and the AMPP study, which has done a big number. So looking at the AHS, you will find that amongst the pharmacological agents, you have the beta blockers, the anti-epileptic drugs established, and then the anti-angiotensin receptor blocker, candesartan, is there. Then you have possibly and probably effective drugs. And looking at the European, where they had flunarizine also, you will find beta blockers and flunarizine amongst the first choice for episodic migraine, and then come in the anti-epileptic drugs. And then the ACE inhibitors and angiotensin receptor blockers are also in the later category, but they are useful. But what you need to do is to try and get familiar with a few of the drugs so that you know that you can use these drugs. You know everything about their side effects, the contraindications. Flunarizine, beta blockers, anti-epileptic drugs, amitriptyline, and candesartan are some of the few you can go with. But more importantly, I would encourage that every patient of warranting or requiring prevention should have some of these alternative treatments going so that they are benign. They have pretty much no side effects if you know how to handle them and if you stay within limits. Magnesium, very useful. We cannot estimate the magnesium levels in every patient and then choose magnesium. Riboflavin, coenzyme Q10. Butterbur and feverfew have got some side effects, so it might be better to stay away from them. And now, since we are having these three agents, riboflavin, magnesium, coenzyme Q10, coming in a combination tablet, it might be worthwhile using these drugs in addition to whatever pharmacological options we are going to use. And when do we use Botox or botulinum toxin? That we will come to a bit later. So you choose, you get familiar and choose based on patient and headache profile, based on contraindications, based on side effect profile, and cost. Cost is another factor. You've got to keep the cost low because these are long-term drugs and many patients drop out because of cost. Some of the contraindications you need to know: beta blockers, asthma, COPD, diabetes, peripheral vascular disease, bradycardia, divalproex, PCOD, liver, pancreas disease, hair fall is a side effect. Don't give in pregnancy if there's a plan to conceive. Topiramate with depression, avoid. Renal stones, avoid. Glaucoma, be careful. and cognitive jobs. If a pilot comes to you with migraine, do not use topiramate as a first drug. If suppose you have an investment banker, don't use topiramate, please. Side effects, beta blockers, look at, understand that there could be fatigue, giddiness, minimal weight gain, some amount of depression, erectile dysfunction in males, divalproex, hair loss, weight gain, and topiramate, cognitive problems. And with flunarizine, you got to be careful for sedation. You got to be careful for depression, extrapyramidal features when used for very long. And therefore, when you start these drugs, you have to start low, increase slowly, give an adequate trial for 2 to 3 months, evaluate periodically, readjust the dose, look for side effects, and you can combine drugs where necessary. Be careful. If the lady gets pregnant, please stop the medicine. Understand that prevention is a dynamic process where you keep changing. You keep modifying all the time at follow-up. And if there are some background disorders, then you can choose the drug according to the disorder. For example, with hypertension, angina, you would go with beta blockers, calcium channel blockers. With depression, you would definitely have an amitriptyline there. And if it is migraine and epilepsy together, you would have an AED over there. So these are opportunities which you should use of going in for a twofer, where one drug would treat 2 disorders. And rational combination therapies are some things like beta blockers and topiramate. Beta blocker goes with pretty much most of the thing except calcium channel blockers. You would be careful. And amitriptyline goes with pretty much everything. So nutraceuticals, they go with almost all the current pharmacological options. Now, what are the drawbacks of the current pharmacological drugs? Their safety and tolerability issues are there. They have a delayed onset. They don't work in all people and all patients, and adherence is low. And so therefore people drop out. And this is where the alternative treatments come in. Now, there are some terminologies which we need to be clear over here. Now, what are alternative treatments? What we are using now, they are the conventional treatment. The current pharmacotherapy is conventional. And what is used in addition, they are the complementary treatments. What is used in place are the alternative treatments. And so when everything is combined, it's called integrated treatment. So these terminologies. So conventional would be the allopathic medicine or the Western medicine which we are using. Complementary is along with conventional treatment. Alternative is in place of conventional treatment. But what we need to do is what is called in the acronym is CAM, complementary and alternative, when you integrate the best of all of the above into a safer model. And now this is coming into vogue in the field of headache medicine. So there is a lot of interest in using alternative therapies for headache medicine for the simple reason that it has been noticed there is no big trial which has proven the point for all these agents. There are enough trials for magnesium and riboflavin, but side effects are much less. And so therefore, the options which are being used now in addition to the current pharmacotherapy are magnesium, riboflavin, coenzyme Q10, alpha lipoic acid, petacities or butterbur, parthinum or feverfew, and recreational drugs like cannabis, LSD, psilocybin. These are all being used more for cluster headache, but not for migraine. For migraine, it is the first 3, magnesium, riboflavin, and coenzyme Q10. Now, when do people want? Patients themselves sometimes ask for these things. People prefer, and the indications are when there's a poor drug intolerance, a drug tolerance, when there are contraindications to pharmacotherapy, and sometimes when there is an excessive use of analgesics or there's significant stress, and when people have heard from others, then they also go in for other systems of therapy like homeopathy, Ayurvedic, in preference to Western medicine. Now, as far as the 3 agents which I talked about, magnesium, the mechanism of action, low magnesium levels give rise to more migraine, and it's associated, it works through cortical suppression, spreading depression suppression, neurotransmitter release, aggregation of platelets, and it prevents vasoconstriction. So there are many mechanisms of action for magnesium, and the levels are difficult to estimate. The levels are very limited in the extracellular fluid. And so therefore, studies have been done without estimating the levels necessarily. And this is the one person who has done maximum study is Alexander Moskov from New York. And there was a pilot study he did with 40 patients. He estimated the levels, 50% had low magnesium. And with 1 gram intravenous magnesium, there was a significant improvement in these patients. Menstrually related migraine, again, magnesium is very useful. Magnesium is useful also in children, and the contraindications are kidney disease, and used in excessive dose, it can produce diarrhea. So one has to be careful of that. And magnesium citrate is the commonest form, up to 600 milligrams is very safe. Riboflavin, these have a vital role in membrane stability, and 400 milligrams daily for about 3 months, you will see a significant improvement in many of the frequency and severity drops. And so therefore, this can be combined along with magnesium and coenzyme Q10. The dose is a little on the higher side. 100 milligrams 3 times a day is what is ideally advocated. And there are studies to indicate that usage of coenzyme Q10 reduces the frequency and disability, and it's very useful in pediatric migraine. Along with this, you go in for the non-pharmacological options, out of which CBT, relaxation training, biofeedback, and then the physical treatments. And some people also go for acupuncture, traditional Chinese medicine. So these are all together, they produce an improvement. So if you would like to put it across stage by stage, this is what I would call layering. The first step would be to use your pharmacological options along with alternative nutraceuticals. If it is chronic migraine, go for botulinum toxin. It works in a large number of patients, but it may not work in all. It is, along with topiramate, the only preventive drug indicated for chronic migraine. There is no role for botulinum toxin in episodic migraine. Along with this, go in for physical therapy, behavioral therapy. That is step 1. If step 1 doesn't work, then you go in for step 2, where you can go in for the anti-CGRP monoclonal antibodies. Now you're having the small molecules, the Gepants. Rimegepant is also coming in as a preventive. And you can then go on to step 3, which includes neuromodulation and supraorbital neurostimulation using Cephali is already available to us. But you can go in for neuromodulation and invasively if you want to, and the patient is refractory and not improving, then neurostimulation. Botox, the preempt protocol is followed of 31 sites. How useful is it? In my experience, it would work in about 50% to 60% of times. It doesn't work in all. And you need at least 3 doses, quite expensive, 3 doses to be certain that Botox is working for your patient. It's useful only in chronic migraine. It can be used in addition to the other options. And we are looking at, in the future, CGRP monoclonal antibodies. CGRP is a potent vasodilator released during migraine. Infusion of CGRP will induce migraine. And the Gepants are for acute treatment. Now it is being used for preventive treatment also, but for prevention, it is the subcutaneous injection, intravenous, also one of them, of monoclonal antibodies. And 4 of them are developed for preventive treatment. They are administered subcutaneously and intravenously. They have very quick action. Within a week, you will see an improvement. They have a sustained efficacy for over a month. 28 days is the half-life usually. So once a month is the dosage. And 4 of them are available. To us, erenumab is the only one which works on the receptor, which is available to us, given subcutaneously in a dose of 70 milligrams. You would consider this in patients with high disability who failed multiple classes of preventive therapy in patients with medication overuse headache when there are comorbidities. And it has a better tolerability. Side effects are minimal. Long-term side effects in the last 5 to 7 years have not been seen. And when you go for neuromodulation, these are the three options you have. Transcranial magnetic stimulation, supraorbital, cephaly, and the vagal nerve stimulation or gamma core. And sometimes you can buy time by using occipital nerve block. But otherwise, invasively, you do occipital nerve stimulation and SPG stimulations, phenopalatine ganglion stimulation. And finally, the last two slides, I would like to say, why are we talking about preventive treatment today? If it is so simple, if it is so hunky-dory, why are we talking about this? Now, I've just put together two slides on what I see happening in practice. And with a hand on your heart, you have to tell me that this is not what you have also seen. Number one, customization is not being done for preventive treatment. Very little time is spent on planning out the preventive treatment with keeping in mind the patient profile, headache profile. Time is not being given to educate the patient. Everybody doesn't go away knowing exactly how the long-term use of preventives is going to pan out for himself. There's not enough focus on a satisfying acute treatment option. Drugs are not chosen according to stratification of the disability. There is no MIDAS estimation. There's no hit 6. A lot of people end up using the same favorite drug always, even the same brand name. There are some who like flunarizine. There are some who like beta blockers. There are some who like topiramate. That's not the way to choose the preventive option. You don't get it right the first time. You have to do a trial and error. There is something called pharmacogenomics, and that is why different drugs are needed for different patients. You have to follow up, you have to titrate, you have to look for adverse effects, you have to give an adequate trial, you have to make sure there's compliance, you have to make sure there's adherence, you have to look at comorbidities, you have to look for risk factors, you have to look for coexisting illnesses. You have to see what you can combine. You have to see what you can not combine. And you have to look for drugs with different mechanisms of action. When you go for polytherapy, gone are the days when people said, at the level of a neurologist and in tertiary care, you are not going to be successful with just monotherapy for many of your migraine patients. You have to look at polytherapy too. And choose the prophylactic according to the headache profile. And children, they would do better with drugs like propranolol, flunarizine. Pregnancy, you should know what you can give in pregnancy. Propranolol, amitriptyline, no topiramate, no divalproex. What you can give in the elderly, try and stay away from amitriptyline in the elderly. When treatment fails, you have to analyze why my treatment has failed. Should I be taking help from somebody else? Should I be calling in a psychiatrist? And finally, there are some patients who don't respond, do what you may. So preventive treatment is a dynamic process. You need a lot of empathy. You need to be taking care of the patient's despondency also. In summary, I would say that what we need in the future is a preventive with proven efficacy, which improves the quality of life with very few adverse effects, with high adherence, easy to administer. It works where other drugs fail, and it is cost effective. If you combine conventional pharmacotherapy with nutraceutical options for maximum benefit, I'm sure you will have a lot of success. And if you understand that migraine management is the art of conveying the science, and finally, it is well said that patients respond to physicians who respond. So if you are kind to your patient, if you are kind at follow, that patient will improve much faster than just a single visit for a patient who has chronic migraine. Thank you.
Thanks, Dr. Ravi Shankar, for a fantastic presentation, as usual. Can we have all the panelists on board, please? Just a moment. Yes. So before I start questions and panel discussions with everybody else, may I request everybody to kindly put on their cameras? Yes. So we have 12 panelists, and I will try to involve as many people as I can. So my first question is to Dr. Ravi Shankar. So we evaluated the role of riboflavin, and it is a published trial in patients with chronic migraine and very frequent migraines, and we found very good results. So what would be the dose in case you want to give riboflavin alone in patients with migraine?
It would be ideally in a dose of 400 milligrams per day, and at least for 3 months. And I think that is the dose you were also using for your study.
Yes.
And combining it along with other drugs, you will find that the efficacy is definitely better.
Okay. Dr. Reddy, Dr. Bharat Vishnu Reddy.
Sir.
Yeah. So where would be your choice for these cerebral metabolic enhancers in your treatment prophylaxis for migraine?
Sir, I started using it as a combination therapy with single normal routine agents of pharmacological things, along with single dose combination. I mean, single daily combination of this combination of riboflavin with Q10. Sir.
Okay, so how do you find the results?
Sir, the need for the further increase in the dose of pharmacological agents is slightly better when compared to the previous things.
Okay, Dr. Anirudh Moore, are you there? I think he has not there. He's not there. Dr. Varun Kataria.
Yeah,
so,
hi.
Hi. So what would be your choice for management of migraine in females, particularly of the childbearing age and in pregnant females?
So specifically in childbearing age, definitely we would avoid valproic acid and topiramate. Then it depends on the patient-to-patient profile. So if the patient is obese and mood is also low, we would avoid beta blockers and flunarizine. If the patient has a little problem of sleep, then amitriptyline would be ideal choice. If the patient does not have any asthma or any pre-diabetic, then propranolol would be ideal choice. And in many of these cases, coenzyme Q, adding coenzyme Q and magnesium also sometimes helps along with this preventive treatments.
Yeah, thank you. Dr. Piyush Jaiswal, could you throw some light on the management of migraine in pregnancy? You are on a mute, Dr. Piyush. Dr. Piyush, you are muted. You have to unmute yourself.
So sorry. Thanks for this. Dr. Kataria, I agree with Dr. Kataria. He already has nicely summarized that COPD and asthma patient and all those things. And I'm very agreeing to those migraine and those Migrium, this combination Q10 and all. I'm very agreed to that also.
No, my question was in pregnant ladies. He just highlighted in the females. Dr. Vivek Nambiar, would you like to throw some light on this? Management of migraine in pregnancy.
Yeah, because of the
very much
legal issues, we usually avoid these agents. Like we use only these nutritional agents, especially folic acid. So folic acid and riboflavin is often the favored one for the pregnancy, because from various points of view, for our protection also from for the legal issues of pregnancy and fetal malformations, we avoid usual agents like all the higher agents. So we usually prefer folic acid and riboflavin in the pregnancy.
I would invite a comment from both Dr. Rauf Hashmi and Dr. Ravi Shankar on this. Pregnancy and migraine. Because this is a very, very important and a pertinent question.
Very true.
Thank you. Thank you. May I please? Yeah. Actually, management of migraine in pregnant females is a very important issue. As Sir has already said, we should first try to try non-pharmacological treatments. We should avoid triggers like sleep deprivation in these patients. We should try to manage their weight. If they don't respond to these, then obviously riboflavin would be one. And class C drug would be propranolol. If patient does not respond to anything, then propranolol is a drug which can be tried in pregnant females. Obviously, other drugs are U category. We cannot use those drugs. But definitely, if we improve their sleep hygiene, their feeding behavior, avoid triggers, most of these patients can be managed without drugs. But if we need drugs, then beta blockers, I would advise, would be the drug.
Dr. Ravi Shankar?
Yeah, I would agree with Professor Asmi. Now, the catch situations here are when you are treating a lady in the conceivable years, you got to be very careful at every visit. You need to ask them whether they're planning to conceive, because quite often we go with divalproex and then they suddenly come back after 2 months of using divalproex and 3 months and telling us that they are now pregnant. Yes. So you got to be careful right from then on. So if at that stage they need a preventive, then that itself, at that time itself, you could go with beta blockers and stop the other drugs like divalproex and topiramate. Even flunarizine is not advised. Then once they get pregnant, then what are the preventives which are allowable? The nutraceuticals, of course, you will be able to use them. Magnesium is a choice which you can use. But in addition, the pharmacological ones, and what I do in practice is I take out 2 or 3 reprints from standard good textbooks and good articles and keep it with me all the time. And I then tell them, because I think Dr. Nambiar was raising the point of litigation. So you could go first with propranolol, and then amitriptyline is allowed. And if there are daily migraines, then you can buy time by giving an occipital nerve block. And you can show them the reprint and tell them that this is what I'm going with. And this is the only way that we can reduce your frequency and severity. And subsequently, the moment they are a little better, you can wean them off the preventive. So for the minimum amount of time required to reduce their frequency and severity, it is worthwhile going with propranolol and amitriptyline during pregnancy. Of course, divalproex and topiramate are totally out. And then comes the question of what happens during lactation. There again, the only additional thing which might be allowed is divalproex, in addition to all these beta blockers and amitriptyline, which you can still use in lactation. The one thing which you avoided in pregnancy, which can be allowed in lactation, is divalproex. So it is difficult choice, and you have to be very careful. You talk to the gynecologist also sometimes, because they might say no. So best is nutraceuticals, if necessary, the other drugs. Sumit, from your experience, what are the choices that you would add?
Exactly the same, sir. Exactly the same. Beta blockers in low dosage are good, but one has to be a little conscious in terms of a very regular antenatal checkup, because it can cause mild placental hypoperfusion. And if you're giving amitriptyline, then about 2 weeks before the expected date of delivery, it needs to be tapered off, because it can cause mild neonatal hypoxia. So yes. Apart from that, exactly the same. Nutraceuticals, if not working, beta blockers. If still goes on, amitriptyline. Dr. Neha, what would be your choice for management of migraine in extremes of ages, which means kids and elderly individual? And elderly, because I'm 53 now, I will call it beyond 60.
For elderly, are basically divalproex. I will prefer divalproex, topiramate, propranolol, beta blockers also. Hypertension is also there. So usually these are hypertensive, so it would help in that also. Amitriptyline usually I will avoid, because it can cause drowsiness, such types of symptoms. For kids also, I think propranolol, amitriptyline, these drugs will be preferred drugs. Then depending upon the
on nutraceuticals in this age. nutraceuticals and cerebral metabolic enhancers. What is your take on these drugs in these extremes of age?
In extremes of age, nutraceuticals can be used.
Okay, so my choice would not be sodium valproate in older people because it can cause tremors. Because tremors is something which many patients of these group already have, either essential tremors which have worsened, or they might be having associated Parkinson's, which might be worsened because of using divalproex. Yes, amitriptyline after the age of 60, particularly in males, is not a very good choice because it can not only worsen an angle closure glaucoma, it can also trigger off urinary problems. So I think otherwise I agree with you completely that nutraceuticals should be a good choice. Dr. Parthasarthi, could you kindly? Yes. So
for pediatric patients, antihistamines like cyproheptadine I have tried. And again, I have always, the mothers are very concerned about the side effects of all these things, and most of the times they would have already tried some of the other drugs, and they would have Google searched the adverse effects, and they come to me, sir, we don't want that drug. So in that case, I will tell that this is a good drug and it will increase the appetite. So all the mothers are happy with cyproheptadine. For the elders, as we have discussed like that. So I have a question. Can cyproheptadine be used in pregnancy? Because as per the FDA, it's I think B, the category B. So I personally don't have an experience. Can one of the seniors please guide regarding the use of cyproheptadine in pregnancy?
I personally have not tried cyproheptadine in females and in the time of pregnancy. It makes a logical choice, but I have not tried it.
Yeah, I have not tried it either. Definitely, I think you're right. It can be used, but it is better to stay away from something which is not being used in pregnancy. So it can be, but better to take care of ourselves.
The magnesium can be used in elderly, I think, sir. It will improve the GI effects also. Some of them are having constipation. I feel that magnesium improves the constipation along with the headache thing. So it has a double effect along with that. So they are few of my patients are happy alone on 500 milligram magnesium once or twice daily. So maybe that can be like we can tell them also that if you are having constipation along with headache, this is the best drug.
Correct.
Yeah. So Dr. Anirudh, what would be what would be your take for chronic migraine use? Because episodic migraine is still a relatively easier thing to treat, but once you go in for a chronic migraine, then it becomes an artwork rather than science.
Sir, in my case, I generally prefer topiramate wherever it is possible to give for long-term chronic migraine, and I also prefer low-dose amitriptyline for like chronic migraine long-term. Apart from that, even nutraceuticals are a good option in such cases. Sir, I just wanted to ask one question since you mentioned about beta blockers in. Can we use beta blocker in third trimester of pregnancy? Because there is a risk of neonatal bradycardia. So
yes, that's what I'm saying. So beta blockers in low dosage can be used.
Okay.
You have to be very regular with the antenatal checkup and the IUGR criteria for the child, because for the fetus, because it can cause placental hypoperfusion. Neonatal bradycardia is usually not very severe if it happens, but a more balanced risk is IUGR because of placental hypoperfusion.
Okay, sir. Okay. Thank you. Thank
you. Dr. Bharat Vishnu Reddy.
Yes, sir.
What would be your play for the new drugs on the block, like anti-CGRP antagonists?
Sir, haven't used it. I have no idea about how they work. Yes.
That is interesting because this is a new kid on the block, and I think it is time that we start working on it. Dr. Ravi Shankar, sir, I think you're the best person to put highlights on this.
Yeah. Now, it is, we have used it in about 6 patients, and the trial results, of course, are known and published now, from which includes the Indian patients also, which I think Sumit might have been a part of the trial also. Yeah. Now, in practice, we have used it in about 6 patients, and the results have been fantastic. In fact, I have used the word fantastic because some patients who had tried Botox, who had tried everything else, chronic refractory migraine, and we've just given them about 3 injections so far, 3 months. And they are already talking of spacing out the drug because of the cost. Can we take it once in 2 months? We are now feeling much better. We don't mind a drug holiday, and we would like to take it beyond the 1 month half-life. So they want to strategize now to save costs, but they are very happy because they've been able to drop their routine medicines, and they are feeling that they are more functional. The quality of life has improved. And as I can see it, they're pretty much, even the injection site reaction they talk about, not there. And I do not tell them about the possible side effects of constipation. We have not seen constipation in any of the patients so far. The numbers are very small, but we've chosen probably the right patient. One was an MOH. The MOH has been handled without detox, no steroids, no inpatient care. And so MOH has been handled. The other 2 are refractory migraines. So I would think that the patients who have gone for repeat doses are very happy. And the ones who have gone for a single dose, they are still 50%, they are feeling better. So I don't know whether some of these are super responders, because 20% of their experience of the foreign trials and other, there are super responders. But at the same time, they also have seen non-responders. So at present, we are getting good results. So Sumit would like to add, or Professor Rauf?
Can I add some point? Sumit sir, can I add?
Yes, sure,
Like,
sure.
I also had some 4 to 5 patients on Erinumab. I have not used any other Eptinezumab, anything. Only Erinumab I have used. I think as Ravi Shankar was mentioning, the results were fantastic. And I stopped the medication because they also are saying about stopping it after 3 months. So 2 refractory patients who were actually, they were really bad. Like they were on 3 to 5 prophylactic medications, including topiramate, valproate, everything. And thereafter failed, and chronic bad migraine. So we tried it. It was fantastic in the sense because the response was within 1 week. So that is very, because usually whenever we give something, it will take 6 to 8 weeks. The response was so fast and it was consistent. So one patient developed muscle pain, severe muscle pain after 3rd injection, and we have to stop it. One thing because of the financial issue, second because of the severe myalgia, and thereafter they recurred. They have started getting other repeated episodes after about 3 months. So by 6th month, they developed the patient developed pain, and I've restarted. They came for again for injection. Patients are happy, but only thing is the presence of the financial burden. So and actually, as sir was mentioning, we used to space these injections, but I think overall the effect is good. And one patient developed constipation, refractory constipation. Other patient developed a severe myalgia. Otherwise, there was no injection side effect or any other major side effects. But cost is the only issue.
Yeah, so I was a part to both the Galcanezumab trial and also the Erinumab trial. So the trial responder rates were fantastic, actually, and we have done the internal analysis before publication because both of the trials, MOVIC data is already out. But Galcanezumab Indian subgroup data is going to be out probably in the month of December, because the trial is now closed and it's now under publication and review. So very, very nice results. And I started using MOVIC, not Erinumab as it is available in India. So MOVIC is available as an auto-injector syringe. So there was a model photographer who had a lot of exposure to bright lights, and that was her job. And it was impossible for her to work because of these frequent migraines. So she procured the Imovig from Dubai. So she purchased the initial 3 injections from Dubai, and even before it was commercially available, we started using it. So she is so happy with this now that it is 6 months, and now she's going ahead with further treatments by the Indian subgroup of Arenumab, that is the one which is marketed by
Novartis
now, Ensorix. So, Dr. Yatin, what do you think is the role of sodium valproate in current migraine prophylaxis?
So,
Divalproate sodium.
Yeah, so the role is quite good. What I have experienced is especially in younger adolescent age groups, males, if we rule out the reproductive age group females, it has shown quite good results. But of course, the side effect profile, if we look at the reproductive age group and weight gain in some patients, is one of the limiting factors. But in other patients who do respond, they do respond well on divalproates.
My choice of sodium valproate would be for people who are thin-built,
yes, sir,
and who have a significant amount of behavioral issues.
Correct.
Because it has got a membrane stabilizing effect and also some degree of mood stabilizing effect.
Definitely,
So,
sir.
Dr. Amit, before we end, I think I would like to have Dr. Amit Aivale. Is he there? I think he is not available now.
He has left, sir. He has left.
Okay. So I think we have had a very fruitful discussion in this meeting. And I must thank Dr. Ravi Shankar, sir, for giving us this excellent overview of the role of various prophylactic agents in the management of migraine as prophylactic agents. I would land over the proceedings to Dr. Rao for the further carrying off for the meeting.
Thank you very much, sir. It was really a very enlightening discussion. Although I don't have personally any experience of giving monoclonal antibodies here in Srinagar, but 1 or 2 patients had come from outside state, wherein they had got these injections and they are doing very well. And as was said earlier, they feel it's a wonder drug. They have very good response rate. But if you see the NICE guidelines, there also it's mentioned that if these drugs don't work, if there's no responder rate more than 50% in 3 months, then we might have to stop these drugs. It has come in the NICE guidelines. So in that case, what would be the, the treatment if these anti-CGRP drugs fail? So that would be a difficult. I think we have to go back to Botox, and I don't think, I don't know, that's a question to be answered. But let us see once we give more of these drugs and what happens afterwards. So it was a very good discussion. Thank you very much. Thank you, Sir Ravi Shankar Sarji. It was my honor to be with you, sir, and especially Dr. Smith Singh ji. Very nice discussion. I will now hand over mic to Mr. Dr. Chakrabarti, sir. Is he? Dr. D'Souza, yeah. Dr. D'Souza, is he here? Is he online?
Yes, sir.
Yeah. Thank you very much.
Good evening, doctors. On behalf of INTA's Aesthetic Division, I would like to thank you, Dr. Ravi Shankar, for your very lucid and practical approach to the preventive treatment of migraine. I would like to thank you, Dr. Rauf Hashmi, for chairing this live webinar, and to you, Dr. Sumit Singh, for so deftly moderating the panel discussion on this relevant topic. This webinar has truly been meaningful, with the clinical experience sharing by all the valued panelists, namely Dr. Vivek Nambiar, Dr. Varun Kataria, Dr. Neha, Dr. Partha Shati, Dr. Anirudh More, Dr. Piyush Jaiswal, Dr. Yatin, as well as Dr. Bharat Vishnu Reddy. Finally, I would like to thank the more than 250 participants of today's program that has helped making today's program a grand success. Thank you, everybody. Wish you a happy weekend ahead. Thank you very much, sir. Thank you to all of you.
Thank you.
Thank you very much.
Thank you all. Thank you, Sumit. Thank you, Rauf.
Thank you,
Thank you,
Dr.
sir.
Ravi.
Thank you so much. Thank you.
Thank you.
Thank you.
Good night.
Good night.